This training is the 6th webinar in the I-STARR training series, and it's the 2nd all audience webinar. So what does that mean? So it means that the content covered in this webinar will be germane to a diverse group of recovery housing stakeholders, including those who own, operate, manage, or otherwise assist in the day-to-day functioning of recovery housing, as well as researchers, payers, and policymakers alike. So this month's webinar will focus on medications for opioid use disorder, or MOUD, and will serve as a primer on medication-assisted recovery for beginners. Next slide, please. And so I am Carmen Masson. I'm a professor of psychiatry in the Department of Psychiatry and Behavioral Sciences at the University of California, San Francisco. I co-lead the I-STARR project with Amy Miracle, who is a research scientist in the alcohol research group at the Public Health Institute. The team also includes co-investigators Sarah Zemore and Lenny Jason, biostatisticians Mina Subbaraman and Libo Lee, and communications specialists Diane Schmidt and Dustin Kiesvo, and our project coordinator is Quinoja Capitini. Next slide, please. So we're also very fortunate to be working with an advisory board, and the I-STARR project's activities are guided by a 17-member advisory board that's comprised of diverse leaders from across the country. While most of the advisory board members wear different hats, they represent recovery and recovery housing leaders, treatment providers and payers, national policy advocates, as well as researchers and educators. And some advisory board members may be in our audience today, and I'm excited to share that one of our board members is serving as the presenter for today's webinar. Next slide, please. So we're excited to hear from today's webinar presenter, who is also a member of the I-STARR Advisory Board, Dr. Andy Tompkins. Dr. Tompkins is the director of the Zuckerberg San Francisco General Hospital Division of Substance Abuse and Addiction Medicine. He's also a professor in the Department of Psychiatry and Behavioral Sciences at UCSF. Dr. Tompkins is the recipient of NIH, SAMHSA, and industry-sponsored research grants in the areas of patient navigation, chronic pain, opioid use disorder, and he's also a distinguished fellow of the American Psychiatric Association and is the chair of the Minority and Underrepresented Caucuses of the APA Assembly. So with that introduction, I'd like to welcome to you to this group, Dr. Andy Tompkins, and I'm going to hand that over to him now, the presentation. Thank you.
Okay, and thank you, Carmen and Amy and everyone who helped set this up, including Diane, who helped make sure the slides work perfectly and look beautiful. So again, I'm Andy Tompkins. Next slide, please. And we're first going to start with some polling. So you don't have to worry that you're going to get some lectures. You're going to start with what you know. And so the first thing, I just want to know who's in the audience with us. And so the question should have appeared on your Zoom. And it says, what best describes your professional role as it pertains to recovery housing? And you can only choose one thing. And I'm going to be along with you. And after that, you should have question number 2, which is the following is the best medication for opioid use disorder? And the next 2 questions just give a sense of what you already know about this topic, because a lot of us bring our own knowledge here. And so there's no, I want you to choose, in your opinion, knowing what you know now, what is the best medication for opioid use disorder? And then lastly, number 3, how long should a patient or client be on a medication for opioid use disorder or MOUD? And again, is it less than 1 month, 1 to 3 months, 4 to 6 months, or however long the patient or client is willing to take the medication and it's working for them? And after everyone has submitted, including myself, the questions, we'll give you a little bit of time. And again, I just want to sort of get a sense of where we are, who we are, and how we can best use this time together. And so whenever Diane or Amy thinks that everyone's answered, we can go on and see what our results were. Okay, so appearing on the screen, let's see. So we have a wide variety of people that are here. So welcome everyone. And the most common response was something else. So maybe we have to work on our categories, or there's just so many different people here today. And I just want to say thank you. And then which of the following is the best medication for opioid use disorder? This was a little bit of a trick question because as you'll hear, there's no real best medication for opioid use disorder. We try and make that decision between the patient and the doctor. And what I always say, the best one is the one that the patient will actually take. But we'll get into that a little bit later. And I'm glad that people had a wide variety of answers as well, meaning that you probably have had experience with these medicines. And we'll get into a little bit why I don't think the question was exactly right, but detoxification is the best. I think it was supposed to be not one, neither of the medications or none of the medications. And we'll get into a little bit of why detoxification may be problematic for patients. And lastly, it seems like a lot of people were saying however long the patient is willing to take the medication. That's what I believe. Each of the patients will come with their own preconceived notions, and we'll talk a little bit more about why I often say, let's give it a year on a medication to see, how best we're going to do with it. But I do like that. That's a very good place to start, however long the patient is willing to take the medication. So next slide. And I'm going to remind myself to put a timer because we want to make sure that we have time for questions at the end. But again, the title of our slide is going to be Medications for Opioid Use Disorder, Medication-Assisted Recovery for Beginners. One thing you should note, as a part of DSAM, I operate San Francisco's largest opioid treatment program or methadone program, the nation's first buprenorphine induction clinic. And I've had a lot of clinical trial experience with extended-release naltrexone. So I've given this patient to these medications to thousands of patients, and I bring that experience with me today. Next slide. I'm also a lover of pop culture. I come from Kansas, although I now live in San Francisco. So this is a picture of the famous Yellow Brick Road. And we're going to go on a journey together. And it's not going to be long. We only have 34 more minutes, but we're going to go over 3 things. We're going to review, first off, why the medical community believes that opioid use disorder is a chronic illness or chronic disease. And I'll talk a little bit about the neurobiological aspects of that. And we'll get to go to medical school together just for 30 minutes. And we'll understand what a disease is, why addiction or opioid use disorder is an example of that, and then why that benefits from medication. And then I'll provide an overview of 3 FDA-approved medications for opioid use disorder. Those are called methadone, buprenorphine, and extended-release naltrexone. There are other names that you'll see, such as the brand or trade names, but those are the 3 medicines that we'll be talking about today. And at the end, I'm going to start off the conversation or end the conversation by identifying ways in which an MOUD can support recovery within the context of recovery housing. So let's get going on the Yellow Brick Road. Okay, next slide. You'll also see some movies. I'm a child of the 90s, so this is Train Spotting, which details people with heroin use disorder in Scotland, and some really good descriptions or exposures to people going through withdrawal. But why did I say that addiction is a disease? Well, since we're all in medical school now, we're going to go to our basic textbook of pathological disease called Robbins. And the medical community defines a disease as an abnormal pathological condition that affects all or part of an organism. And in order to be a disease, you have to have an etiology, which is, how does it start? You have to have pathogenesis, so it has to change the body in the case of a human being in some way. Morphologic changes are the changes that we can see using either our naked eye or imaging in the case of brain illnesses or other ways, so that something has happened to that body. And just because something has an etiology, causes change in the body, if it doesn't reach clinical significance or cause problems, then it doesn't reach a disease. But as we know, addiction causes a lot of problems, and we'll talk a little bit about that. Next slide. And so I compare SUD addiction on the left to type 1 diabetes, which we all consider a disease. As a reminder, type 1 diabetes it is what happens when you develop diabetes when you're young, so oftentimes before the age of 18, and your body destroys parts of the pancreas, which are called the beta islet cells. And without them, that's the only cell in the body that produces insulin. And so therefore, type 1 diabetics often come to clinical attention when they stop producing insulin, which causes problems. And what it does, it causes there's a loss of insulin. And so you have very high sugar levels, which if not treated, can cause coma and death. It's chronic, so that if you give the person with type 1 diabetes insulin, they can live a normal and healthy life. But of course, like any chronic illness, taking your medication is easier said than actually done. So we'll turn to addiction. And with addiction, we know a lot about this illness. We know that it runs in families, so that certain persons are born with a genetic predisposition to having addiction. Oftentimes, if you have an early life experience or adverse life experience in childhood, you can have an increased risk of developing addiction or substance use disorders later on. And of course, you have to be exposed to the substance. You actually have to take the substance. So in certain countries or certain time periods when drugs weren't available or aren't available, then it's really hard to develop a substance use disorder. However, so we're in medical school, pathogenesis, there's a change in the brain. And specifically, and you'll get to see a picture of the brain, which hopefully people like to see, I'd like to see. There's a change in the reward pathways. And there's a change specifically in a brain hormone called dopamine. And we'll get into a little bit more why that's important. And you actually can see this in morphologic changes. There's usually an increase in dopamine release when you give an opioid. And then it changes the opioid receptors, which are sort of the keyhole that the opioid, which is the key, has to attach themselves to cause an effect. And the effect typically is a high that a person gets with an opioid. But chronically and over time, you've heard of tolerance or needing to take more and more. That happens because there are additional changes to the brain. And this brain change is long lasting. So it stays around even after a person were to stop using that substance. And of course, why we get involved as persons that are in this community, either in treatment or research or policy, is because that chronic substance use becomes a problem to the patient. And as we know, oftentimes once it develops, it also is a chronic illness. Next slide. So hopefully I've given you the overview of why I consider addiction or substance use disorders a chronic illness. And what you have here is it compares relapse rates to other chronic illnesses, which are not stigmatized, which we encourage people to get treatment for and we screen for, including asthma, which is a difficulty breathing, often requires medications to help prevent that. Hypertension or high blood pressure, which some people are just born with and some people develop later on in life, but can be treated with diet or medication or exercise. And then type 1 diabetes. So just because you know you have you're type 1 diabetic, oftentimes you're a child or an adolescent or a young adult, you don't like taking insulin. You don't like not reducing your sugar intake. And so therefore you have what we call a relapse. So you have a worsening of your symptoms. You stop taking your medication. You're not stigmatized for that. You're just encouraged to get back and go. And how can we work with you? Can we change the medication? The same thing is with addiction. Relapse, we like to say, is a part of the trajectory of a lot of people with opioid use disorder. And why we stigmatize it, why we encourage people to leave their treatment if they relapse, is something that really we don't do for any other illness. And so I'd like people to use this knowledge to talk to people about why we think substance use disorder is an illness, it's chronic, and relapse is common, and it's just as common as with other conditions. Next slide, please. Here's the picture of the brain that I promised. You don't have to read it for those that are, you can come back to this and read the small print, but it basically shows that opioids do a lot of things. The front part of the brain, which we call the prefrontal cortex, is about decision making, and opioids over time changes the way that people make decisions, so that opioid use or prevention of withdrawal becomes the main driver. The amygdala and the midbrain are parts that are in the middle and deep within the brain. Sometimes we call that the lizard brain because it's seen in lizards and birds and lots of other animals. And this is where craving and emotional responses to opioids take place, and where you can see changes in the brain in terms of the opioid receptors and the release of dopamine. And lastly, the brainstem, this is where the overdose risk happens. So if you have an opioid in this section, it actually tells your body to stop breathing. And of course, if you stop breathing long enough, you can have an overdose. And if not reversed, it can result in death. So all of that, when a patient takes a lot of opioids in the body, what it does is it actually decreases opioid receptors in the brain. So you have to take more of it to get the same effect. Your body does produce its own opioids called endogenous opioids, and your body stops producing those because it doesn't need to, because you're taking in so much opioids. And we have what's known as a new set point. And this is why people use, after many months or years of using an opioid, they say, I only use to feel normal. And why they say that is because the brain has changed and reset itself so that it only functions normally in the presence of the opioid that the person has been using. And so therefore, when they don't have it, the brain doesn't work as well and causes withdrawal. Next slide. So that wasn't too hard, right? We've gone through medical school, you passed a test, it's wonderful. You've learned about opioid use disorder as a disease and how the brain changes when you use opioids chronically. So if you can think of this question, if the brain now needs an opioid to function normally, why not provide an opioid medication that is less likely to make someone high, needs to be taken once a day so it's easy for the patient instead of having to use 4 times a day in the case of heroin or more times than that with fentanyl. You want to prescribe something that's legally allowed to prescribe, so we have to deal with the laws and regulations of the United States. And if you're listening to this in another country, the laws of the countries that you live in. And you want something that has a safety profile, so one that we've used. And thank you for the questions. I'll get to those at the end, but keep them coming. So therefore, you want a medication with those 4 properties. But we all know that changing the brain chemistry or fixing the brain chemistry is not the only thing often that a patient needs. So it's often combined with a lot of other supports, such as recovery housing. Next slide. And how do we diagnose addiction? So we diagnose it using criteria from the Diagnostic and Statistical Manual, Section 5. I happen to sit on the APA Assembly, and so I'm involved with approving these conditions, which is really fun to be able to do. So in 2015, we came up with substance use disorder, which is a continuum of symptoms. So we have many symptoms here. You don't have to have all the symptoms to have an opioid use disorder, but if you have at least 2 of them over a 12-month period, then you're qualified as having at least a mild opioid use disorder. And moderate and severe just means you have more and more symptoms, and you have more significant problems with your disorder. But just because you have tolerance does not necessarily mean you have a use disorder. But if your life really is taken over by looking for and using and recovering the opioid, then we say that you probably have an opioid use disorder. These are clinical. These symptoms are endorsed by patients, but they should be reviewed by a clinician who can make the accurate diagnosis. Next slide. I also like drag queens. So this is Detox, a famous drag queen from RuPaul's Drag Race. And what she's here to show you is that detox does not work for the majority of people, as I said before. And what we know is we've done a lot of research on this. A lot of people have really looked at this from many years, so starting with the 50s, 60s, and 70s, the early days of methadone till today, we've seen that the vast majority of individuals relapse to opioid use within the first year, and most oftentimes within the first 2 months. And this is even worse in the era of fentanyl, which is where we see ourselves today. And when they relapse, there's a high risk for fatal and non-fatal overdose in the 30 days following detox. And so now recommendation from specialty societies like the American Psychiatric Association, the Association of Addiction Medicine, American Society of Addiction Medicine, California Society of Addiction Medicine, a lot of other organizations recommend that people be on an opioid use medication for opioid use disorder for 12 months or longer to achieve optimal care. It doesn't necessarily mean a patient wants that. And so we still work with patients that may not want this, but that's going to be the recommendation that I have for the patients that I see. Next slide. So we're on the yellow brick road. We're getting there. We're meeting the scarecrow, which is a fun character. This is the scarecrow from The Wiz, which is being brought back to Broadway in the coming year, but was of course done by Michael Jackson and colleagues back in the 80s. So I encourage you to watch that movie too. And this is looking at the entire country as a whole. We want to know how many people are at risk for opioid use disorder, how many of those have an opioid use disorder, and then more importantly, how many of those actually know they have an opioid use disorder. And this data comes from 2016, which is the last time that we had all this data together. It's really hard to get. And at that time, there's between 11.8 and 90 million individuals that were taking an opioid and therefore were at risk for developing an opioid use disorder. And at that time, there's a little over 2 million individuals with that opioid use disorder. But unlike with HIV, where we really want people to know they have an illness, only half of those with an opioid use disorder actually knew they had an opioid use disorder. And less than half of those actually sought treatment at any time during the following year before these surveys were done. Less than half of those actually started medication as part of their treatment. Less than half of those were retained for treatment for 6 months or longer. And less than half of those achieved remission. Which is still a somewhat controversial topic, and we can probably talk about in the spicy debate afterwards. But it shows you the treatment gap, which is the red, that we have a long way to go if we want to make sure that every person with an opioid use disorder is offered a medication in the year that they have that diagnosis. We have a long way to go. But it gives you an overview of what we're working with and how we can look for improvements. Next slide. So I mentioned we have 3 medications, but let's take a look back. So those have all been approved by the Food and Drug Administration. So this just takes a snapshot of 11 years in time and looks at all the different anti-cancer drugs that were approved during that 11 years. And each year, and it got more and more towards 2020, you have 10, upwards of 50 new drugs each year. So adding those all together, you have hundreds of different options to offer people with cancer. And we just aren't there yet. But we do have medications, and we are working really hard to find new ones. But you know, certainly if we as a society want to spend as much money on researching cures for addiction as cancer, we might be able to see this slide in our lifetime and hopefully within the next 10 years. Next slide. So what I've done here is I'm going to be giving you a snapshot of the medications that are available alongside the staggering numbers of individuals like my patients who died this last year. Over 100,000 people die of an overdose, and the majority of those are opioid related in each year beginning in 2021. Next, and that is, even though we've had methadone since the 1970s, we've had the naloxone reversal agent since the 70s. Buprenorphine was approved for treatment in 2003. Next, we had extended release naltrexone approved in 2009 in the United States. Next. Then we had extended release buprenorphine, which is buprenorphine once monthly injection, came on the market in 2017. Next. And Brixadi, which is another formulation of extended release buprenorphine, which was approved, but is now only available in the United States as of 2023. So we're doing our best to bring these medications to market, and people still kept dying. This is not what happened in HIV. In HIV, as we all know, when we find medications that worked, people were scrambling to take them, and they did really well. And now we have the mortality rate of HIV in this country is so much lower. But the mortality rate for opioid use disorder keeps going up, despite having these medications available for patients. Next slide. So we're going to go fast and furious, you caught that pun, over the 3 medications. And each time we'll go into the medication, I'll give you an answer to the following questions. What does it do? Where can a patient get it? And are there any side effects? And so we'll do this again and again and again. And hopefully each time you'll be so more excited to learn about the next one. So next slide, please. We're going to start with methadone. I'm not going to go over these slides. The next 2 slides talk about the history of methadone, and it's a medication with a lot of stigma. And it started with the development of methadone in the 30s by German chemists. They lost the war, and the United States got the medication. And so it became approved by the Food and Drug Administration in 1947 for the treatment of analgesia. But what this also shows you is that this medication and the treatment of opioid use disorder in this country are incredibly regulated. It's still against the law for a doctor to prescribe and a pharmacy to fulfill an opioid that's not a Schedule 3, 4, or 5 for the treatment of opioid use disorder. You can go to prison. And in fact, in the 20s, they were arresting 30,000 physicians in a year who were doing this. And so it's really a highly regulated, highly stigmatized, illicit history of methadone. Next slide. And so I encourage you to review these slides afterwards if you want to know a little bit more about the history. But finally, methadone became available for the treatment of opioid use disorder as a research project in 1970. In methadone, it was shown to be highly effective. In fact, it was thought to be a miracle cure. Next. And the opioid treatment program, OTOP, that I oversee, was one of the first in the country. We celebrated 50 years in operation. And so we thought this was a miracle cure, so we wanted a lot of people to have it. But unfortunately, what happened was that there was a lot of backlash from many different people. And so that the rollout of methadone was you only could use it in a licensed opioid treatment program. And there's a lot of regulations around it from the federal government, the state government, and even local governments saying we don't want methadone clinics in our backyard. And so with the war on drugs in the 1980s, the number of people on methadone actually went down. However, as you see, when HIV/AIDS happened, it was shown that that methadone was a good treatment for prevention of HIV seroconversion, and actually could stabilize people that were out of treatment and get them on medication. And so with the HIV/AIDS came a resurgence of methadone, and it's continued to go up, and we'll go into a little bit more about that. But I encourage you to read more about the history of methadone, and there's some wonderful documents here that are linked here if you want more interest in that. Next slide. So again, we're going back to medical school, and I have 3 medicines, and they do slightly different things in the brain, but they all affect the opioid receptor. And methadone, as you see in green, the more methadone you give, the more effect you get. It's called a full agonist. And that's why, we worry about side effects when we're first starting someone on methadone, and it takes a little while for their body to get used to it. Buprenorphine at lower doses functions just the same way. So the more buprenorphine you get, the more good effects and bad effects you get. However, about halfway through the dosing, the more you give, you get no effect. So it stays, and that's called a partial agonist. And so it just turns the receptor on partially, unlike methadone, when it binds, has a full effect on the opioid receptor. And naloxone, the opioid overdose, is a complete antagonist. So although it binds to the receptor, it does nothing. And so therefore, and it also blocks opioids from getting on there. And so what it can do is it can reverse an overdose. So it turns on the breathing centers in the brainstem. It turns on the opioid receptors in the gut, which causes a lot of diarrhea and other side effects. And extended release naltrexone is the same. It does the same thing, but it's given either in a pill form or in a long injection, so once monthly injection. So that's an antagonist. So they all bind to the opioid receptor, but they do different things. And that's why we have 3 different types of treatment. Next slide. That was easy. You're doing well. You're given lots of questions. Thank you so much. So methadone, we know a little bit about its history, but what does it do? Again, it's a full mu opioid receptor agonist. It's widely distributed throughout the body, including in your lipids. That's why you see methadone stay in your system a lot longer, and the withdrawal doesn't start for many days after taking it. And what does it do? It helps to stop withdrawal symptoms. It helps to minimize or stop craving. So the really thoughts that you have that drive people to use. It can result in reductions or even stopping illicit opioid use. It prevents opioid overdose death, which is one of those amazing things. And it keeps people in treatment. But what happens is that because it's a full agonist and because it stays around in your body a long time, you don't want to start it too quickly because it doesn't reach a sort of a steady state except for after 3 to 5 doses. So you have to take it for 3 to 5 days before you get the real effect of the methadone. And so every time you go up, and that's why at the clinics, it takes a little bit longer than the patient wants to get up to a steady state dose. But it does a lot of wonderful things for people, and that's what it does. So methadone, what does it do? And it's often given in a liquid at licensed opioid treatment programs, which is why you see the red liquid. It's cherry flavored. There's not a lot of options for patients. It's either cherry flavored or no flavoring. And what I've learned, the vast majority of people prefer the cherry flavoring. Next slide. And it works. As I said before, it works at reducing opioid use. And we go back in time. So methadone has been available since the 1970s, and we've researched it, including my colleagues. I'm in Baltimore right now. So these were done by my mentors and published in highly respected journals. And it shows if people were on a low dose of methadone versus a high dose of methadone, which at that time was 80 to 100 milligrams, the higher dose did better in terms of helping people stop opioid use. And you had a lower rate of having a urine drug screen that was positive for opioids. So what that taught us is that you don't want to keep people at a low dose. The higher dose you get, the better effect you get. And then this slide was by one of our very own, Carmen, and her colleagues. They really looked at, okay, we thought about detoxification. What happens if we detoxify someone on methadone versus keeping them on methadone? And we look at days in treatment. So 365 is a year. So this was done over many years. And what you saw is that if you detoxify people, they dropped out of treatment relatively quickly. Whereas if you gave them the opportunity to stay on methadone, whatever their dose may be, they were very likely to still be in treatment years later. And so what that is teaching us is that we want people to stay on methadone as long as they're willing to take it. Next slide. And it not only works in the United States, this is showing a study done in China and Taiwan. And what it looked at is over time, if you were on methadone, what was it likely that you were going to die? And die from an overdose versus any cause. And what that shows is that the mortality or dying went up when you came off of the medication, whereas it went down when you were on the medication. And if you were on it longer, you got more of a benefit. And so that's on the left side. So what's showing is that the medication works not only in the US, but all over the world. And the longer you give, the better an effect you get. And then here I mentioned the HIV/AIDS. This is just the paper that showed such a high. So this is how many people actually converted during this time month. So over 18 months, people not in treatment, 1 in 5 of them got HIV/AIDS, whereas very few, if at all, who were on treatment or even had partial treatment, so even exposure to some methadone, really reduced your rate of HIV seroconversion. And that is a wonderful thing. And that's why methadone had this big comeback in the 90s. Next slide. And it does a lot more things. And again, we only have 35 minutes, so I can't go over all of them, but it works in improving mood, anxiety. It helps people with family reunification. It increases goal-directed activities as a job, a caretaker, a school, volunteer. It reduces recidivism or reincarceration. And it also helps keep people out of the emergency room and the hospital. So for the payers out there, it really does save the system a lot of money. Next slide. Where can you get methadone, you might ask? And this, you might say, this is a wonderful invention. So there is a website that shows every OTP throughout the country. Every state has at least one, except for Wyoming. So Wyoming has outlawed methadone since the late 90s, early 2000s. We're trying to work on that. But as of now, you cannot access methadone for opioid use disorder in that state. And as of the last time this was reported, we have 512,000 patients in OTPs, or licensed opioid treatment programs, and the vast majority of them are on methadone. Although it's just a reminder that just because you're in an OTP doesn't mean you can't get offered any of the other medicines. And you do have a small amount listed there. Next slide. And because you're in a comprehensive level of care, you also get counseling, the opportunity for daily observed dosing of the methadone buprenorphine, on-site other options for care. So it's really a holistic system of care for the patients. Next slide. However, methadone does have side effects, and these are listed there. And what is a reminder that we went over the receptors in the brain, but the opioid receptors are throughout the body. And so therefore, whenever you have an opioid, which methadone, buprenorphine are, you're going to have some opioid-related side effects, and those are listed here. Next slide. And there are side effects of the system of care that we have in the US, which is not the same in other countries of the world. So the patient has to come to the clinic frequently. They have to come, before COVID-19, they had to come mostly daily at the beginning, and then could earn take home through the ability to take their methadone at home over long periods of time. Often clinics are open limited hours, and they're often very much earlier than most of the other rest of medical care. And there's staff turnover. So patients having to go to a new counselor or nurse therapist a lot, and they don't like that. And then of course there's insurance issues. So this is rarely available free of cost. And oftentimes if you don't have the right insurance, including Medicare, you don't get treatment. Medicare only started covering methadone 2 years ago. And we're still struggling to do that in my clinic. So just because it covers it doesn't necessarily mean that the clinic has found the right way to actually accept it. And it takes a little bit longer for the patient to get on a good dose of methadone. So oftentimes, if you're seeing them early in treatment, they're not looking well. But over time quickly, they do get well very quickly. Next slide. So methadone, very fast, furious. Go back to the slides if you want to learn more. Buprenorphine, also known as Suboxone. What does it do? Where can a patient receive it? And what are the side effects? Next slide. So buprenorphine, unlike methadone, comes in a wide variety of formulations. The one formulation you don't see is oral. So if you swallow buprenorphine, that's a bad thing. It's not going to be absorbed, and it's not going to work. However, if you put it underneath your tongue, either in a tablet form, or in this case, it looks like a film strip, then it can be absorbed and get in the body and work well. Buprenorphine, unlike methadone, now comes in injections. So it comes in a weekly injection, which is Brixadi, as I just mentioned, just became available this year, as well as extended-release buprenorphine, which is a once-monthly injection. So therefore, the patient doesn't have to remember to take the medication every day, and it just stays in their body, and it slowly seeps out and does the good work of the medication without them having to take it every day. What does it do? So like a reminder, it's a partial receptor agonist. So therefore, it doesn't have as much of the side effects. And when combined with naltrexone, which is Suboxone, it can help prevent misuse. So if a person tries to inject the buprenorphine into their body, they don't like it. And so then they learn not to do that. Although it can be given once monthly, it also can be taken multiple times a day, unlike methadone. And so therefore, that can be really helpful for patients with opioid use disorder and chronic pain. And it comes in many different ways of getting in the body or formulations. So a lot of options with buprenorphine for our patients. Next slide. And it works. You're not going to become a ballet dancer and do these wonderful performances that you see on the left, but it's really going to stop withdrawal. It's going to really, because you first have to take it usually when you're in a little bit of withdrawal, it stops it right away. And then over time, it reduces craving, it reduces opioid use, and it prevents death. And it's just a reminder that the opioid receptors, when they're not, the opioids are not there, the person does experience withdrawal, and it can be quite distressing for them. Next slide. And like with methadone, there's been a lot of research on it, some of which I have done. I even wrote a chapter on buprenorphine. It's a little old, I should update that, but it works. And I just presented a couple of slides and studies. The first one was done in a large study of veterans in the VA health system and looked at whether or not they were receiving buprenorphine or not, and followed them a long time. And what you showed on any given day, if you're on buprenorphine, if you were not receiving buprenorphine, you were 4.33 or 433% times more likely to die by suicide or overdose than on any day that you were taking buprenorphine. So, it was just an incredible figure. No cancer drug really can do that. And, buprenorphine can do that. Methadone can do that. And people aren't taking it. We've got to change that. And then we looked at, whether or not people are on higher doses of buprenorphine. This was a study that just came out and looked at 16 milligrams, which is what's considered a good dose before the era of fentanyl. In the era of fentanyl, higher doses do better. And what we have here is staying in treatment. So the orange line is the length of time that someone is in treatment. And again, it's days. So it's followed people for 6 months. And so higher better is the same thing with buprenorphine. Next slide. And where can you get buprenorphine? So with the Data Waiver Act of 2003, when buprenorphine was made available, it now can be used, it can be in an opioid treatment program, but it now can be used in any office-based setting, in somebody who can write a prescription, and a community pharmacy that has it can fill it. So therefore, it's much more widely available. You can even do it over telehealth. That just happened in the era of COVID-19. So you could be on the phone or on Zoom or however you like to see your provider. You can get started with buprenorphine right then and there. That means I'm over time. So I'm so sorry. We're going to go through this a lot quicker. And you don't have to have an X waiver. So now anyone with a DEA license can write this medication. Next slide. Buprenorphine does have side effects. It doesn't taste very good. It can cause sedation like buprenorphine when starting, and it does some of the other things that methadone does, but just is less. So because it's a partial agonist, you have less rates of constipation, less sweating, less weight gain, less sleep disorders, and less risk for overdose, unlike with methadone. And also, because you have an injection, those can be having some side effects, such as mild pain. They'd leave a little bit of a lump. And very rarely, if you do it incorrectly, it can cause a skin blister or some local tissue damage or necrosis. Next slide. And the other side effect is how you get on buprenorphine. This has become more challenging in the era of fentanyl because if the person is not in withdrawal and they take buprenorphine, they can have what's known as precipitate withdrawal. However, fentanyl came on the market in 2015, and so we've had a long time to really develop better strategies. And I mentioned one here that was developed by my colleagues in San Francisco at our OBIT clinic. And we can do microinduction, which means giving a little bit of a dose over time while they're still using. We can give them a large dose called the macroinduction, typically in the emergency room or in the hospital, or we can do the typical way. And all those will get people on to buprenorphine into a good dose, usually within a couple of days, unlike with methadone, which oftentimes was a couple of weeks. So it can get into their system a lot quicker and get them feeling well a lot quicker. But it can be challenging. Next slide. Lastly, extended release naltrexone or Vivitrol. What does it do? Where can you get it? And what are the side effects? Next slide. So what does it do? So as a reminder, it's an opioid antagonist. So it completely blocks the opioid receptor. You don't get any effect. So it blocks, if you put an opioid in your body, you're not going to feel the effect. But because of that, you really have to detoxify or stop using opioids for a specific period of time, typically 7 to 10 days, before you can get the injection. So it's really meant to prevent relapse in somebody who's already detoxified. Next, you can also, it's great because it also has been approved for alcohol use disorder. So if you're using both alcohol and opioids, it can be a really good choice. And there's been increasing evidence that for people that are using speed or methamphetamine, that also can go down when using extended-release naltrexone. So it can be used for a lot of different substances. Next slide. It works. And when compared to usual treatment, it can keep people free of relapse. So that's return to use was much higher with extended-release naltrexone compared to usual treatment. However, this is a study that my colleagues and I did when we looked at all the studies of extended-release naltrexone. What we found was that if you started the trial when the person needed to be detoxified and then go on to extended-release naltrexone, they did worse in terms of actually getting that first injection compared to if you started it after they'd been detoxified, such as if they were in the jail or in a treatment center, they've been detoxified, they're much more likely to receive that first dose if that situation occurred. Next slide. However, and this is the sad part and why we recommend likely that it's a second line treatment for a lot of patients, is that people rarely stay on it. So this is looking at all the studies and just looking at 6 months. So remember, methadone buprenorphine was talking about years. Some of the studies, only 1 in 5 people continue to receive the medication for the full 6 months. And that's because there's no withdrawal when somebody were to stop it. So they start feeling well, they don't like the injection for whatever reason, and then they stop it. And so when we want people to be on a medication for a year or more, it's really hard to get a person to be on a year or more of extended-release naltrexone. And that's why we often say it's a second-line treatment, although it is FDA approved. Next slide. And this is just showing you the numbers, looking at the total of people on a medication. The vast majority of them are on buprenorphine. The second is methadone, and only about 5% at the time of this data, which is really hard to get, were on extended-release naltrexone. That number is likely to be about the same in 2023. Next slide. It does have side effects. Remember, the worst is that it can precipitate withdrawal. So they really need to come off of it and not be on dependent. And rarely can cause some side effects like liver inflammation, which is why we do a blood test when a person is on it for long periods of time. And some people can get depressed mood or anxiety, although those can be treated, especially if it's an underlying depressive disorder that because the person is no longer using opioids, they might discover they have a depressive disorder and need treatment. So those are often mild and shouldn't lead to treatment discontinuation. And as a reminder, injections can cause problems such as mild pain and infections if done without sterile technique. Next slide. So we've gone through the yellow brick road and we've reached the end of the Emerald City. So how could medications for opioid use disorder aid recovery houses? And these are my opinion. They really need us as a community to do the research, but I believe it can really help people stay in recovery housing. So retention, retention, retention. And of course, patients who continue with medications are likely to continue in other aspects of their treatment. And they're not going to be using illicit opioids, so they're less likely to face removal from recovery housing because of return to use. And because a lot of these programs are associated with specialized psychiatric and other services, you can actually have easier access for patients to get a wide variety of other treatments. And lastly, a lot of the programs offer job training. We encourage people in recovery to start working for my clinics. And so there's a lot of opportunities for job training, which is often a requirement or a goal for people in recovery houses. So next slide, I believe, is resources. I'll just leave these up briefly, but there's the chapter I wrote with my colleague, Eric Strain. There's some articles that show the different buprenorphine initiation protocols and why extended-release naltrexone we don't recommend as the other 2 medications. And then there's my website, GSAM. So if you're in San Francisco, you need access to care. We have a lot of great options for you, even those for patients without insurance. And then a lot of websites for you to help provide in your community someone to provide medications for opioid use disorder. Next slide. And with that, I'm open for questions, and I'll turn it over to Carmen. Seem to be a lot of them.
Thank you so much, Andy. What a wonderful presentation. So now that we've heard from an expert on the topic of medications for opioid use disorder, I want to give the audience members the opportunity to ask questions they may have or share their experiences with respect to MOUD and recovery housing. You can raise your hand virtually in Zoom, but we also have a staff monitoring the chat if you want to drop a question in there. So do we have some questions, or Amy, do you want to address some of the questions in the chat?
Yeah, so we had a lot of questions come into the chat for Dr. Andy. I'm going to skip to the ones pertaining to medications for opioid use disorder. Is there any evidence for or against using MOUD as preventatives?
It depends on what you mean by preventatives. If you want to unmute yourself to tell me what that means, but in terms of prevent overdose, yes, there's a lot of evidence to show that it prevents overdose. But if there's something else that you had a question about, I need you just to help define it.
So I think this came in pertaining to someone who is using marijuana as preventing fentanyl use at some point.
So it's because you have to have an opioid use disorder to qualify for the treatment. It wouldn't be available to someone who was just using marijuana to prevent the onset of a use disorder. And that just has to do with the regulations around who can prescribe it and why you prescribe it. So that unfortunately would not be helpful for those that are just using marijuana that might be worried about an overdose. However, extended release naltrexone, we've been trying to use that in patients with methamphetamine use disorder who routinely have fentanyl in their system and have overdose risk. And so for that population, given that you can use that medication off-label, potentially could be an option, but that should be between the patient and the doctor who would be prescribing, or provider who would be prescribing that.
We also had some questions come in about methadone. What is the average dosage level administered to folks in the beginning of methadone treatment?
Good question. Although we have standards of that, it's going to vary widely based upon the clinic that you go to. And also what opioid the person was using. So what we found in the era of fentanyl, people are primarily using fentanyl or using heroin with fentanyl, the dose is going to be higher. So as I showed that there's a wide variety of dose ranges that a person could end up on. Oftentimes the first day they'll start with 30 milligrams and go up by 10. So the maximum, according to federal regulations of methadone, is 40 milligrams on day one. And then you can go up, but depending upon the clinic and the person prescribing it, the going up may be slower. In our clinic, we try and get our fentanyl patients within 100 milligrams in the first week. And oftentimes people will need anywhere between 100 and 200 milligrams before they are at a good dose for them. If they were using heroin, oftentimes I want them to be on 80 to 100 milligrams as the goal dose. But again, they'll start low and they might go up slower because they may not need as much if they're just primarily using heroin or other prescription opioids. But again, there's no goal dose, so it's hard to, if you're in the house and people are on a wide variety of doses, I just say whatever dose is what makes them feel comfortable. Prevents them from, stops them, if their goal is to stop using opioids, that stops them from having cravings and stops them from using, is the dose that's needed for them.
And Dr. Andy, I'm going to give you one more question before we have to move on. But this is about methadone again. And what is the best plan for those who wish to get off or to stop methadone?
That's a good question. So that's an individualized discussion. So although I may recommend a person try it for a year, some people may want to come off of it. And we like to go the low and slow route with methadone tapering. So at our clinic, we oftentimes will recommend people taper off over the course of a year so that they don't feel any withdrawal. And that they stay with us even after they're stopping their methadone to make sure that they don't return to use. Sometimes they say I want to be off in 30 days. We can try that. It's usually not recommended. It wouldn't be my first advice for them, but we talk about with them why they might want to do that. But if they can give us 6 months, if they can give us a year, or if they want to go even over the course of several years, it's going to be a lot more easier for them and a lot likely to be successful in terms of them coming off and then staying off of opioids.
Excellent. And I think I'm going to have to cut off questions at this point. But given how many have come in and how amazing this presentation was, I'm really hoping that we can have you back again. So Carmen, I'm going to hand things off to you to wrap things up.
Great. Thank you, Amy. Next slide, please. So this has been a great discussion. I would like to give you a heads up about some relevant activities that are coming up in the next couple of months. First, as you can see, I want to bring your attention to what's happening with respect to the pilot study component. For those who are unfamiliar with this aspect of the I-STARR project, in addition to serving as a hub for recovery housing for persons taking MOUD and providing training webinars on these topics, we also provide pilot study funding. A request for pilot applications was issued last month, and you can learn more about the application process on our website. And the process starts with researchers who are interested in applying for these funds by submitting a letter of intent. And these letters are due on November 13th. And all of these letters then are reviewed by our team, and we'll make decisions about which projects are competitive. And those projects will be asked to submit a full application by the end of the month. Again, the I-STARR pilot study component and the application process can be found on the I-STARR website. I also want to bring your attention to other activities that are happening in the month of December. We have a operator provider webinar on MAP proficiency, proficient recovery residences. And then on the other webinar we have in the month of December is focused on researchers. It looks at the pros and cons of mixed methods designs. We also, next slide, please. We also want to give our audience members a one last thing to do in December is that one of our pilot studies that's led by Rachel Winograd at the University of Missouri, St. Louis, is going to launch a national survey on MOUD barriers in recovery housing. And she's going to collect data from operators of 250 residences across the country and for 500 residents who are living in these residences. And Rachel, or someone from her team, I think, is here to tell us a little bit more about the project. Okay, if not, I want you to stay tuned and we'll share more about this in December. Okay, I want to thank everybody, but before we want to sign off here, I want to talk directly to the audience members who are registered for the 12th part provider operator or researcher training series, as well as those who are considering registering for it. And the webinar counts toward the 12 trainings in the training series for these 2 tracks. As a reminder, those who attend all 12 webinars in the series will receive a certificate of completion and will be provided the option of being identified on the I-STARR website as someone who's completed the training. So if you're enrolled in or attend all 12 webinars in the provider training series, you can earn up to 12 NADAC CEU credits given at the end of that series. So if you're registered for the provider series or think you would like to register for it, we would like you to fill out a brief webinar evaluation, which needs to be completed so that we can count your participation in this webinar toward NADAC CEU credits. And the evaluation will pop up on your screen in a separate browser when you exit the meeting. And again, if you're not registered and would like to register, please go to the I-STARR website. So now, if you have to miss a webinar, we will be building a platform onto our webpage for people to view the webinars there, and all the webinars on the will be on the website. Those who are registered and view the webinars on the platform not only can have the viewing count toward completion of the series, but they can also send questions about the content to I-STARR team members and provide feedback about the webinars. So regardless of whether you're registered, for either the provider or the research training series. It's been a delight sharing this information with you. And we hope to see you back here at a webinar down the road. So stay tuned and we'll definitely stay in touch with you. Thank you so much for attending the webinar. Okay, thank you, Andy. That was fabulous.